I'm here today with Johanna Moore, and she is the lead author on a groundbreaking new article, and I'll use that term lightly, but it's huge. It is now out in Resuscitation Online, clinical paper on head and thorax elevation during CPR, and I think it's well worth a discussion. Johanna is affiliated with University of Minnesota, Hennepin Healthcare, and I assume a few others, but too long to mention. But it's a privilege to have you here with me to discuss it, because you're the lead author on this stuff. And would you agree that the title's a bit of an understatement, given the starting results?
Yeah, it's funny. I think a lot of these scientific papers, the implications and the conclusions are so important, but then they're somewhat understated in the title. It's like how science works. Yeah. But at the same time, it's really cool to write something like this is associated with improved survival, right? I mean, that's a pretty strong statement.
Yeah, so let's talk about it a little, because like I said, I mean, this is, to me, I mean, I can use all the old words. I mean, it's paradigm breaking. Some people have said, I think Paul Pepe, one of the co-authors, has said it's the biggest thing about changing physiology in this field in 50 years. So when somebody says that to me, particularly in science, I mean, that is like a quantum leap that doesn't always happen. So this is almost like a moonshot, or whatever you want to call it, that I think a lot of us knew was probably true, but we had to finally get it done in a manner that shows to the professional community how it was done. And I think that's probably one of the big things with this. So maybe we could talk a little bit about that, how the process of getting this together and how it was done. Then we can talk about the results.
Yeah. So like you said, this is a paradigm shift. And I think, so traditionally, we've always, with cardiac arrest in particular, it's a condition that's so heterogeneous because the end stage of many conditions is death, right? So, but yet and all our patients come to us in a different way. And they're all in different situations. So somehow we expect that one therapy alone is going to save a life always. And that's just not true. It's just silly to think about one silver bullet saving everybody. So it makes sense that you have to think about this chain of survival in a process and how you can build on that. And so the work that we did, right, is building upon work that Dr. Lurie and others did years before with the invention of active compression, decompression CPR with the impedance threshold device. Using that physiology unlocks kind of the next level, which is now head and thorax elevation. So, and then that's hard to study in a prospective randomized clinical trial, of course, because you've got patients who are effectively dead. They can't give you prospective consent you can't sit in an office and have a coffee and talk about the pros and cons of research. And in this situation, right? So it's challenging to study these questions and answer them. And it's so dependent on the study being correctly done as well. So as the commercial device became available, I, as a researcher, and that's how I'm trained, as a researcher, did a fellowship in the clinical research, and I'm not paid by the maker of the device. I help in the lab, right? And I've helped develop the device, but I have been steadfastly not supported by industry at all, by design. So I felt as a researcher, it's really important as we get this device on the market, that we measure our outcomes, what's happening to our patients who actually get this bundle of therapy, our neuroprotective CPR bundle, as we're calling it now. And so we had an initial data set of 230 patients, and we thought it would be interesting to look at it and just see what we found. And we found a really interesting story, unlocked also by Wayne Kiewicz, who is the old Richfield fire chief, who had a cardiac arrest and had a perfect chain of survival, including full deployment of our neuroprotective CPR very quickly by Edina Fire. And, he had such good perfusion during his resuscitation that he remembers parts of it, which is incredible. And then we saw this in contrast to other sites that were using this neuroprotective CPR bundle, but it wasn't being applied as quickly, right? 20 minutes into the resuscitation. So the very first responder didn't have the device. It was brought to the scene by a duty supervisor 20 minutes later. And then we find, hey, these patients who are getting it later, or some patients aren't doing as well, and some patients are doing great. Why is that? And then we found this time-dependent component. So when we take this data of these 229 patients, we try to make sense of it. The statistician had a really great idea, like, let's compare apples to apples, right? So that, like I was saying, a cardiac arrest population is so heterogeneous. You've got a 96-year-old compared with like a 20-year-old at times. It's not really fair to just lump them all together and say, how did they do, when one's dying of something, some chronic process, and one just had a primary arrhythmia. So our statistician looked at that data, controlled for time from 911 call to CPR, controlled for things like age, sex, witness status, all these important pieces of cardiac arrest that we know portends a good or bad outcome. And when you compare those apples to apples, we match these patients from large prospective randomized clinical trials in the past. We had like 900 patients to choose, or out of 5,000 patients, we matched 900 patients with our 229 patients. So for each patient who got neuroprotective CPR, we had like up to 4 control patients, like apple to apple patients.
Is that, just not to interrupt, is that what you're calling propensity score matching?
That's exactly right. Yeah. So it's not prospective randomized controlled data, which is ideal, right? But impossible, especially in this type of situation, as we're just dipping our toe in the clinical research water. So this is a really good method to try to look at a very difficult outcome like survival, controlling for all these very important factors, trying to keep everything else the same other than just the CPR method. How do things turn out? And compared to conventional CPR, we see these very high odds ratios associated with survival to hospital discharge and improved neurologic survival with the patients who got the neuroprotective CPR. And it's time dependent. So the quicker you get it on, the better odds of outcome that they'll have a better outcome.
Well, I think that was certainly a staggering finding. I mean, it was 4 times better most of the way, which was staggering.
Yeah.
But I think there was some other findings that maybe were more subtly written about in there that were potentially just as much. I mean, you had implications in there about shockable and non-shockable.
Yeah.
You're talking about that?
Yeah, absolutely. So, like we advertise these very like sexy therapies like ECMO, right? That's like the hot topic. But in reality, ECMO is a option for such few patients in America. And even if you have that option available to you in an area like the Twin Cities, only, just a handful of people are going to qualify for that. You have to have it has to be primarily a shockable arrest. You have to be within a certain age range. You can't have certain comorbidities. And I think so ECMO is really for the creme de la creme of the cardiac arrest patients. And so if you got ECMO available to you, great, but what I really love about our therapy, neuroprotective CPR, is that it's available for everybody. There's no exclusion criteria unless you're too large to fit on the device, essentially. And it's all rhythms. And the really gratifying part of this is we're seeing improved outcomes regardless of what your rhythm is. The shockable patients do great with it, but importantly, so do the non-shockable patients. And that's really notable because most patients of all comers of cardiac arrest, the overwhelming majority are shockable or non-shockable patients, like 80% roughly. And so in our patient population, I think 17% had a primary presenting rhythm that was a shockable rhythm. And so, you're never going to have as high of a survival proportion with a non-shockable as a shockable rhythm, but we're seeing this benefit of neuroprotective CPR, that higher odds of survival, even within that non-shockable group. And so especially in the context of things like people are overdosing a ton, right, on narcotics, opiate overdose in this country is still a huge problem. Primary respiratory causes, with COVID and things like that. These are potentially conditions that we can go after rather than just a primary cardiac etiology.
Well, I think that's a real strong message to first responders in ALS, because traditionally, if they come up on a non-shockable rhythm, they're probably going to walk away, right?
Yeah, well, or the traditional thing is you do it for the family, right?
Yeah. I mean, you're going to make it look good. You're going to make it look good. Yeah, you're sitting there in your mind knowing we're going nowhere.
Not going to do well. Yeah.
We're going nowhere.
Yeah, so that's right.
Huge. That's huge. And again, I mean, I've heard another one of your co-authors, Paul Pepe, who seems to be good at this stuff. He
Yeah.
said it's the equivalent to a firefighter of getting the AEDs, 20 years ago. This
Yeah.
finding that you can now do this.
Yeah.
Well, that's cool. And I think the message from the article also, maybe comment on this for me. And you mentioned it briefly early on, but I like to come back to it because, like you said, it's not one magical device. Just because we've added the sequential elevation now, but it's like, hey, we finally got the tuba in the symphony, and it's this,
Yeah,
that's
a great analogy. Yeah.
So
Yeah.
maybe talk
Yeah.
a little to that, because we're not saying, hey, no, you still got to do all these other things well. And I think
Yeah.
maybe the way that you can talk to that too is because if people are going to ask, because, for example, how were the 6 sites selected that you used? They were selected for a reason, and the
Yeah.
reason was this, correct?
Yeah, I mean, I think the initial patient population that we describe, we didn't realize how important this time thing was and performance was. But going forward, especially, I think as we study this, it's really important to have high performing sites at baseline. You have to be able to do the basics well, right? So, there's a synergy here. It is a symphony, and there's a synergy to that. And so you're building off our basic building block is really good, quick, basic CPR. And then do you have a mechanical adjunct? It's like automated CPR, or do you have something like manual active compression, decompression CPR, so you can kind of hammer hard on the chest for at least a couple minutes until you get the head up device behind the patient, and then switch them over to a mechanical device. And then you've also got the impedance threshold device, right, from the very beginning, from any airway. And so it's every one of these devices, every one of these interventions is we know individually has some type of positive prognostic indicator of survival. But when you add them up cumulatively, you can see how all of a sudden, like, we're getting near normal cerebral perfusion pressures in a pig, or Wayne Key, which is waking up during his arrest, because our end goal is really just to restore normal perfusion. And so we'll use any method. It doesn't matter if it's one method or like 5 methods together to get there, right? So we're building upon all this physiology with all these different incremental interventions to get to our end goal.
Well, yeah, and I think Tom Oftrides even talked about it. We're bridging from death to life, and we're throwing more bridges. Very
much. I like to think about it as you can be a little dead or a lot dead, right?
Yeah.
So when you have ventricular fibrillation, or you have PEA, or you have asystole, you're effectively dead physiologically. And what I like to think about is you're extending a window of death. Yep. So if we can push it out, and so we know with things like ECMO, that window can be pushed out to like 60 minutes. With this therapy, it seems like we can push it out to even maybe like 20 minutes or so. You're buying yourself time to get the patient what they need, or you're able to restore blood flow, or get ROSC.
That's a really important point, because when you look at average response times, they do vary, obviously, greatly.
Yeah.
But the reality is, I think the average mean, which doesn't mean anything, is 7 minutes in the US or something like that. So that would be well within the time frame for this symphony to be applied and do well. And even if you're in an area where you're out there at 15 minutes, even at 15 minutes, you were getting a response.
I would want it.
Yeah.
It's better than nothing. Yeah.
So again, what's the message?
You still want your antibiotics, even if you're getting it 6 hours later for your infection rather than 2 hours. Yeah,
I think so. So in the end, would you agree? I mean, I'm trying to get a message here to the first responders, to paramedics, and everybody. What do you think that message is now? It's changed. I mean, I think we've got a different message to them now. And I don't want to quote Jim Valvano, "Don't ever give up, don't ever give up." But I mean, that's kind of what comes out of this. And then it also would be, hey, we have shown what the symphony and what the instruments are and what the processes are that it takes to do this. And you can't just, I don't want to say it in an interview half-ass it, but you can't half-ass it. You've got to go hard on every one of these to make this work.
Right.
So,
I mean, I always, I tell our I think that's, so a good take home message is I tell our medics, when you walk into a cardiac arrest, like expect to get the patient back. Expect success and go hard and give them the care that you would want for your family member. Think about them as your mother, your sister, your brother, grandfather, whatever. And so that always inspires me to give the best care. And you just never know. You never know who's going to wake up and do great. And that's part of the game, right? If we knew that, then it would make this a lot easier. So there's no reason not to go hard, like from the very beginning, and do the resuscitation, expect success. And if you don't get it, that's okay. There will be more, and we have more opportunities to learn and grow and keep going with this technology, this process.
Well, it's like any sports team. I mean, if you think you've got a chance at winning, you're going to play harder. If you don't think you have a chance, you're going to mail it in, like we said earlier. So, I think that's a huge message here. And so to summarize, in a sense, I'd say we're not saying chuck all this other stuff or anything like that. We're not in opposition to existing, high quality CPR. We're not
very much no.
Using the IPD, we're not, in fact, one of the things that we talk about and has also been enabled now is this idea of having all this equipment in a couple of bags. And, we had a great article. I love the title, Carry Less, Do More. And that it's easy to get this on site now and get it utilized. This is not, none of this equipment is hard to implement once you know what you're doing. And so
exactly right.
It's huge. That's great. So, hey, Johanna, what, okay, so now you've done this, now what?
Well, it's not, so this paper is awesome and we're very proud of it, but it's only just really the beginning for us clinically. So it's really just our first description of our first 230 patients we have in this registry. So we now have, we're still collecting data. And we've, from these, we have another paper that we published earlier this year, I guess, about initial probability of ROSC. And so from these papers, we've learned lessons, right, in these analyses. And so we've gone to the sites that already are using this technology and sites that are going to, and we say, look, it's not like you just buy the device and you say, here you go, thanks, you walk away. You get a lot of training with the device. We say, look, this is the best way that we believe that it works, is you do it this way. You do it in these steps. And so we urge you to get it on ASAP. And this is how you're going to get the best outcomes. So that's a new part of the training now that didn't initially exist, right? So we're collecting data in the context of now there's new improved or updated instructions. And so we're analyzing that data in a bigger pool of patients. And so ideally we're going to have, over 1,000 or so to even more geographically spread throughout the country. And so we'll see if the message that we're seeing in this initial 230 patients is still there in a greater subset of patients. And we'll specifically be looking at like the non-shockables. For example, we're presenting a bigger patient population of non-shockable outcomes. So I presented that earlier this year at the Society for Academic Emergency Medicine conference. We'll be presenting it at the American College of Emergency Physicians annual conference next month, and then at at AHA as well. So these are all areas that we'll be looking at. And then, ultimately after that, I think we'd be looking at something like clinical trial, which is daunting, but I think important to really think about now.
Well, I think also, to your point, okay, so this study involves 6 high-performing sites. The reality is we can, as we get more and more sites and bring them up and make them better at the basics, like you said, and get that muscle memory, as in a sense, to what you do. And all these other terms come into play. That concept of a fit group comes in here. It comes in totally. So you can get it, get on site, do it well. People can be interchangeable, and you can move them around and do things. And there's not an emergency medicine organization in the world that can't use that.
Yeah.
It can't get better. I mean, and if anybody says, oh, it can't get better, that's wrong. In my
Yeah.
book. And as a
Yeah.
survivor, I can tell you it's wrong. You're killing people unnecessarily. I can say that. You can't say that, but
Yeah, that's right.
anyway,
That's right.
but
Yeah.
that's what I think. I said, so today, 6, tomorrow, the world, I think is the message. And
Yeah.
I think this is a great start. It's like I said, for people like me that have been fortunate enough to survive cardiac arrest numerous times, I feel blessed, and I'm so happy that this research has come along, and it's only by the dedicated people like yourself and the hundreds of thousands of others that are really at this and won't give up on it, and don't give up in the face of, like you said, this idea that, hey, we can't do, how do you do a clinical trial on cardiac arrest? That's a good one. Yeah, how you gonna, how are you gonna
Challenge.
where they are? Yeah,
Yeah.
you're gonna let some go and some not. Now you're playing God. Yeah, I get that. So cool. Was there any closing statement you got, a big finish, or otherwise it's tough to outdo what you've done, Joanna. It's been great.
We wrote it all in the paper.
Yeah, so you got to read the paper. You got to.
I don't know what else. I don't know what else to
Okay.
say.
Cool.
No, I think the propensity analysis is really cool. It's a tool that's not really used, and it's very helpful in this situation to let us know we have a good signal and what we're doing is the right thing. We need to continue on in this way.
Yeah. Well, I think that's great. I really appreciate your time today to talk to me about it. And I hope we have many more of these conversations.
Yeah,
to come.
absolutely.